very interesting and appealing to all of you. With this small introduction, I would like to hand it over to today's moderator, Dr. Kalyan Kumar Sarkar, to start the session. Over to Dr. Sarkar.
A very good evening to all of you. Very good evening to all the students and the teachers. We've got a very good faculty today. Dr. Samit Swain and Dr. Debanga Sarma. Our chairperson is traveling and he will not be here, but we will manage, and though we will miss his wisdom. Now, the program for the first day of the renal cell carcinoma class are 3 presentations by the students. And these 3 presentations are by Dr. Kishore, Dr. Annab, and Dr. Ajit. May I request all of you to make yourself visible and identify yourselves. And may I request Dr. Kishore to start with his first presentation, Nephromatic Scores and their clinical application. Would all the speakers first identify themselves, their institutions, and then proceed with their presentation?
It's 7 o'clock.
Dr. Tonge is going to speak on nephrometric scores and their clinical application. Kishore, please share your screen. Yes.
Kishore, first introduce yourself. Everybody should know who is Kishore.
Sir, myself, Dr. Kishore Tonge from SCB Medical College, Cuttack, Odisha, sir.
Okay, go ahead.
Sir, sharing option नहीं आ रहा sir. There is no sharing options.
Should be at the bottom of your. It should be at the bottom, in the middle. If you wish, Ruma, start sharing the.
असं केलं मी त्याला असं चोळून एक्सप्रेस करायचं ट्राय केलं सकाळी पण ते नाही झालं ब्लॉक झालेले असणार.
Can I share, sir? Dr. Tonge?
Yes.
Can I share your presentation?
Yes, ma'am.
Okay, okay.
We welcome Dr. Shivaji Basu, who has just joined in. Welcome, Shivaji.
Thank you, Kola.
Is it visible?
Go on to full screen, please, Ruma, and Dr. Tonge, you can start your presentation. Just indicate when you want your slide to be changed.
Yes.
Okay, sir.
Good evening, everyone. Myself, Dr. Kishore Tonge from SCB Medical College, Cuttack, Odisha, with my presentation on nephrometric score. Next slide. Starting with the introduction, as we know, the incidence of renal cell carcinoma is rising today, and it is mainly due to the incidental detection of that renal mass due to advanced imaging, and that may be ultrasound, CT scan, or MRI. As we know, more than 1/3 of the cases of renal cell carcinoma is by the small renal masses that is less than 4 centimeter in diameter. There is a widely divergent but oncologically equivalent treatment options for renal mass, starting from the open nephrectomy to to robotic nephrectomy towards the percutaneous ablation of the renal mass. Next slide. Coming to the radical nephrectomy, there are higher rates of chronic kidney disease and post-op advanced sequelae of the radical nephrectomy. And about partial nephrectomy, this requires technical skills of the surgeon, and it is mainly concerned with the post-op complications such as urinary fistula and hemorrhage. And talking about ablation of the renal mass, it requires feasibility, and main concern of ablation of the renal mass is of recurrence of the malignancy. Patient largely present without symptoms. As we know, greater than 60% of renal mass patients are asymptomatic, and the guiding the principle of primum non nocere means no harm to the patient is especially critical in this clinical space. Next slide, man. Then why we need the nephromatic, ma'am, previous slide. Why we need the nephromatic score? As we note, there are different tumors of renal masses, different characteristics of tumor, and different surgeons that treated these tumors. There is a risk quantification that increasing tumor complexity in respect to tumor size, nearness to the collecting system, nearness to the hilum, and this also correlate with the risk of malignancy and its aggressive histology. The nephromatic scores predict the surgical complexity, and it predicts whether to use nephron sparing surgery versus radical nephrectomy, and whether to use the surgical approach, either open surgery or minimal invasive surgery. There is this also indicates the risk of perioperative complications and oncologic outcomes. And nephromatic score stands, and it gives the communication between the treating physicians, and it gives comparisons of published studies also. Next slide. What are the scores available? There are these scores mainly. Is the renal score that we use today. Then second is the Padua score. Third is the centrality index score. Fourth is zonal Nepro scoring system. Fifth is DAP score. Sixth is ABC score. Then comes MAP score, and last is the Rosco score. Next slide, ma'am. Starting with the renal nephromatic score, which is given by Kutiko et al. In Journal of Urology in 2009. It consists of 5 parameters. 4 are giving points, and 5th is anterior or posterior, that is documented by A or P. The first is the R for radius. Second is E, that is exophytic or endophytic. Third is the nearness to the collecting system. Fourth is anterior or posterior. If it is not clearly visible, then we can give X suffix, or the L means location related to the polar lines. Then spatial suffix H is assigned if the tumor touches the main renal artery or renal vein, that is the hilum, hilar structures. It gives the complexity of the renal mass. It is divided into 3 risk criteria, that is low risk is having 4 to 6 score, intermediate risk is having 7 to 9 score, and high risk is having 10 to 12 score. The range of complexity of renal tumors nephromatic score is from the simplest, that is 4A, to the most complex, that is 12PH, means 12 is points, P is posterior, and H means it is near to the hilar structure, that is renal artery or vein. And in these, the study shows that low and intermediate risk patients, that is 4 to 9 score, were treated with the minimally invasive partial nephrectomy, whereas high risk score were treated with open partial nephrectomy or radical nephrectomy. Next slide, ma'am. Talking about the renal score, it is very useful, flexible, and reproducible tool to objectify the saline renal anatomy. It describes the complexity for doing partial nephrectomy for a given renal mass. It also correlates with approach. Either the surgeon should go for radical or partial, and that is open or lap nephrectomy. What is the duration of operation? What is the ischemia time? Blood loss, complications, post-op renal function, histology, and grade. Next slide. What are the limitations to the renal score? There is a higher inter-observer variability, and it does not predict post-op renal function drop in patients with a solitary kidney. and there is poor correlation with the positive margin. And last but not the least, it does not reflect the complexity with reference to the Hilar nodal mass, tumor thrombus, and the local invasion. Next slide, ma'am. Comes to the second score, that is Padua score, stands for the preoperative aspects and the dimensions used for an anatomical classification. It is given by Ficara v. et al. In Journal Urological European Journal in 2009. It consists of 6 parameters, and from longitudinal location, exophytic rate, that is exophytic or endophytic. Third is the renal rim, that is the tumor is lateral or the medial. The fourth is the renal sinus involvement or not. Fifth is the collective system involvement, and sixth is the tumor size, that is less than 4, 4 to 7, and greater than 7. Padua score is remarkably similar to Nephromatic score, with the exception that the definition of sinus lines and the evaluation of the anatomical relationship between the tumor and the urinary collecting system or renal sinus. Next slide. Next slide, ma'am. About Padua score. Padua score of 8 to 9 had 14-fold, and the score of greater than or equal to 10 had a 30-fold higher risk of complication as compared to the scores having 6 to 7 that is given in study. It predicts the risk of surgical and medical perioperative complications in patients undergoing open nephron sparing surgery. And inclusion of renal sinus involvement as a separate parameter is exclusive criteria for the Padua score. Next slide, ma'am. Coming to the central index score, that is centrality index score given by Simons et al. In Journal of Urology in 2009. It is a geometrical equation, or the calculative method was introduced to categorize the tumor centrality. This method requires a complex geometric calculation using cross-sectional imaging to determine the distance from the tumor center to the center of the kidney. Next slide, ma'am. This C index, that there are various examples given. C index is having 0 to 1.7. As the C index increases, that is the center of the tumor to the distance of the center of the tumor to the center of the kidney increases, means the tumor is going away from the kidney center. The lower is the central extension of the tumor, and nephron sparing surgery should be more feasible with lesser chances of complication in these higher C index patients. Next slide, ma'am. And about C index, 0 C index means it is concentric with the center of the kidney. 1 index means it's a tumor periphery touching the center of the kidney. And it is easy, reproducible, and there is a good prediction of operative difficulty. But it requires a learning curve, and calculation involved near about 14 observations that is calculated, and kidney assumed to be a uniform ellipsoid and tumor to be a uniform sphere. That is not always the case. Next slide, ma'am. Talking about zonal Nepro scoring system, which is given by Hake et al. It's also near about same to the renal score, and it gives the 4 criteria parameters. First is the nearness of the tumor to the collecting system or the renal sinus. Second is the physical zones, that is divided into 3 zones. That is, zone 1 is having 1 point, that is lower pole tumors. Zone 2 is having mid pole, that is lateral to the collecting system, and zone 3 is upper pole, or that is nearer to the collecting system. Third is the radius, that is less than 2.5 to 4 centimeter and greater than 4 centimeter. And fourth is the organization, that is greater than 50% exophytic, or 50 to 75% endophytic, or the mostly endophytic means greater than 75% of endophytic. These also the same points and risk of as that of renal score. Low risk is having 4 to 6, intermediate 7 to 9, and high risk is having 10 to 12 points. Next slide, ma'am. This is an example of 3.2 centimeter mass near to the collecting system, where is the renal score is at 8x, that is in intermediate risk criteria, whereas Nepro score is 11, that is high risk criteria. This is the main difference between the renal score and the Nepro score. Next slide, ma'am. Next slide, ma'am. About a zonal Nepro scoring system, it is simpler, easy to use, and more predictive post-operative complications. It has having better correlation with the stage and complexity of the smaller renal masses. Next slide, ma'am. Coming to the DAPS score, DAPS stands for the diameter axial polar nephromatic score. It is the integration of integration and optimization of the renal and centrality index scoring system is given by Simons et al. In Journal of Urology 2012. It includes the diameter, axial distance of the tumor, and polar distance scoring. Diameter is having less than 2.4 given 1 points, 2.4 to 4.4 is given 2 points, and greater than 4.4 is given 3 points. There is axial distance scoring. If it is greater than 1.5 centimeter distance is then 1 point, and less than or equal to 1.5 centimeter, 2 points. And if the tumor overlaps the axis, then it gives 3 points. Then comes the polar distances score. Greater than 2 centimeter in 1 point, less than or equal to 2 centimeter, 2 points, and overlap is 3 points. And A or P. Next slide, ma'am. This is an example of 3 masses. First is 1.7 centimeter is having 2.1 centimeter score, having 1 point and 2 sections, that is 0.6 centimeter, 2 points, that is the given 4 score. And second is having 9 score, and third is having 6 score. The 1.7 centimeter mass, 5.8 and 3.5 centimeter mass. Next slide, ma'am. Coming to the ABC score, that is stands for the arterial-based complexity scoring system. It is given by Massi Milani et al. In European Urology Journal in 2016. It is a surgical indicates the surgical complexity assessment system that is based on the arterial vascular anatomy of the kidney. It depends on size and importance of the arteries to be controlled in surgery. Next slide. It is divided into 4 categories. Category 1, that is indicates the tumor is involving only the renal cortex, thus encompassing the interlobular and the arcuate arteries. Whereas category 2 is the tumor originating from or extending to the renal medulla and reaching the line connecting the tip of the renal papilla, and therefore requiring the transection of interlobar arteries. Next slide, ma'am. Third is the category 3S, that is the renal mass. S stands for segmental arteries. Renal masses extending into the renal sinus towards the central connecting system and involving the segmental arteries and their branches. Whereas category 3H, H stands for hilum. Tumor is in proximity or involving the hilar structures. Hilum. Next slide, ma'am. Then comes the MAP score. MAP stands for the Mayo Adhesive Probability Score, an accurate imaging based scoring system to predict the adherent perinephric fat in partial nephrectomy. It is the method of determining peripheral fat measurement. The points are given to 0 to 3, and the 4 to 5 scores indicates that is severe complexity of the renal mass, and hence not go for the partial nephrectomy. Rosco score. Rosco stands for the risk of surgical complication score. It incorporates the Padua or the renal score with Carlson comorbidity index and BMI. It is independent predictor of surgical complication and better than Padua score and the renal score. Next slide, ma'am. This is the study done by the Aditya Sharma et al. Published in the Indian Journal of Urology in the year 2018. It is a comparison of renal Padua and C-index scoring system in predictive perioperative outcomes after nephron sparing surgery. It concluded that C-index fared better than other 2 scoring systems in predicting the trifecta outcomes. However, it is difficult to calculate and highest inter-observer variability. Next slide, ma'am. In summary, mainly talking about the 3 main scores, we first is a renal score. It is having 4 parameters that is giving points, and 5th is anterior or posterior. It gives the operative time comparatively easy for urologist and reproducible, but it is having less convenient as we require distance of the tumor from the collecting system in millimeter. That is difficult to calculate in our routine practice. And second is the Padua score. It is having 6 parameters. Therefore, it is 2 more parameters as compared to the renal or nephro score. And renal sinus is a separate parameter in Padua score, but it is not predictive of margin, ischemia, or a complication. Coming to the C index, it has a maximum reproducibility and operative time is calculated C index, but it is having calculation and learning curve is more, as it is a geometrical equation and near about 14 observations should be calculated. Next slide, ma'am. Take-home message will be renal and nephro scores requires only 4 parameters. Urologists might favor these scores over Padua score that includes the 6 parameters, and renal score is quite easy for urologists to calculate, and not a single score is the best scores. Hence, there is area of improvement for the scores to be evaluated, and hence the external validation is required. Next slide, ma'am. Thank you.
Thank you very much, Kishore. I think that was a very, very nice presentation, and thank you for sticking to time. We have 2 minutes for discussions. I think Kishore has followed, has summarized everything, and has given an excellent take-home messages. And may I ask the faculty to if they have any questions. I will ask one of mine. In your day-to-day practice, in your experience in MCH training, how do you use any scoring system, and how does it change your practice? Does it change your practice?
Sir, we usually on routine practice, rounds, sir, in our institute, we usually follow the renal score, sir. That is very easy to calculate on CT scan. And sir, but the management of the patient mainly not depends or changes as the renal score, sir, as day-to-day routine practice, sir. But we calculate every patient's renal score, and it indicates whether to go for partial nephrectomy, or it goes into the high risk for that indicates radical nephrectomy. We always routinely use renal score only, sir. Renal nephromatic score.
Any other questions from anyone? Would you want the radiologist to issue the score on the basis of the CT image, or would you, I mean,
yes.
Do you read the CT images, or you sit on the console and,
yes. Sir, the use of radiologists is mainly in renal score is the distance of the tumor to the collecting system, sir. That is in millimeter. That is not appreciated by urologist, sir. That is given by radiologist. And in our institute, radiologists do not routinely give renal score, sir. That is calculated by urologist only.
Very good. Are there any other questions, anyone? Thank you very much, Kishore. I think you made a very good presentation. May I now request Dr. Onnop Maiti to make himself both visible? I think he has made himself visible, and may he introduce himself and go on to the next presentation, which is focal therapy in renal cell carcinoma.
Sir, very good evening to all the respected teachers. Myself, Dr. Arnab Maiti from RGKar Medical College, Kolkata. I will be speaking today on the topic focal therapy on renal cell carcinoma. Sir, am I audible, sir?
Absolutely. Carry on.
So should I share my screen, sir, now?
Absolutely.
Okay, sir.
I think the students are welcome to use the chat box to put in any questions or comments they have, or discuss amongst themselves whilst the talk is going on, so that there can be some meaningful interaction in the 3 or 4 minutes of discussion we get.
Sir, is the screen visible, sir?
Absolutely. Go full screen.
Okay.
Yes.
Sir, I will be speaking today on the topic focal therapy for renal cell carcinoma. A number of population-based studies reported an increase in the incidence of diagnosed small renal masses less than or equal to 4 cm. Nephron-sparing treatment remains the recommended treatment for clinical stage T1A renal masses, especially in the young healthy patients. Partial nephrectomy carries the same oncological outcomes to radical nephrectomy in treating patients with CT1A renal masses. Over the last 2 decades, thermal ablation has emerged as alternative treatment option for the management of patients with renal masses less than 3 cm in size. Focal ablative treatments are associated with fewer complications and less morbidity. It also offers a viable treatment alternative, especially in patients who might not be medically suitable for extirpative surgeries. What are the advantages? These are less technically demanding than open laparoscopic or robotic partial nephrectomy. They are associated with shorter convalescence and fewer complications also. And they have a minimal impact on post-ablation renal function, with comparable or even better post-operative renal function found when compared with that of partial nephrectomy. It also offers treatment versatility because they can be deployed in open, laparoscopic, or percutaneous procedures. Who are the candidates for these non-surgical focal therapies? Patients, as I told, like with CT1A tumors less than 3 cm in diameter, or for those having substantial comorbidities. Patients with small renal tumors who are either poor surgical candidates or are at risk for renal insufficiency, including patients with solitary kidneys, those with bilateral renal tumors, and those having the hereditary syndrome such as the von Hippel-Lindau disease. Other candidates can be patients with local recurrence after previous nephron sparing surgeries. What are the prerequisites? According to the AUA guidelines 2017, a renal mass biopsy should be performed prior to focal ablative therapies. A renal mass biopsy in a separate session reduces the over-treatment significantly, with 80% of patients with benign lesions opting not to proceed with the thermal ablation. In 2 study series, it has been observed that focal ablative therapies have more 5-year disease-free survival and total effectiveness rate for papillary renal cell carcinoma in compared to the clear cell RCC variants. Relative contraindications for these therapies are cystic renal masses and Hilar masses, while the absolute contraindications include untreated coagulopathies. The modalities for focal therapies include cryoablation, radiofrequency ablation, high-intensity focal ultrasonography, stereotactic body radiation therapy, microwave ablation, irreversible electroporation, targeted embolization, and laser interstitial thermal therapy. The American Urological Association recommends focal ablative therapy should be offered as an option rather than standard treatment in high-risk patients. Now about the first modality, that is cryoablation. Cryoablation or cryotherapy, it is the practice of using extreme cold temperatures to treat a wide variety of pathological conditions. The therapeutic principle of cryotherapy treatment is selective destruction of tumor cells with minimal injury to the surrounding tissues. The cryotherapy employs argon gas-based systems to achieve treatment temperatures of -40°C, which are delivered through the cryoprobes. A particular mention is about the Joule-Thomson principle, where low temperatures are achieved by the rapid expansion of high-pressure inert gas to generate temperatures of -185.7°C within the target tissues. Very low temperature delivered causes the direct cellular damage during the freezing phase and indirect reperfusion injury during the thawing phase. Cellular changes secondary to cryotherapy can be summarized in these 4 main stages, that is formation of extracellular ice crystals leading to hyperosmolar extracellular environment and cell shrinkage, formation of intracellular ice crystals which cause the cell damage, the metabolic activity stops at -40°C, and thrombosis and microcapillary damage leading to necrosis. About the treatment temperature, renal collecting system and renal vasculature tolerate cryoablation without any real long-term injuries. Renal parenchyma usually is destroyed at a temperature of -19.4°C. The preferred target tissue temperature during cryoablation is at or below -40°C. The principle is to create an ice ball treatment zone that is at least 5 to 10 mm beyond the edge of the target lesion. The thermosensors are usually placed at the edge of the tumor to ensure the adequate treatment temperature for the area of interest. The current recommendation is now to perform a double freeze-thaw cycle to ensure complete cellular death. Cryoablation should be performed under a real-time imaging with the treatment area 5 to 10 mm beyond the margin of the tumor. It was seen in the previous slide also. The treatment should be balanced against risk of suboptimal treatment with short cycles or a risk of tissue fracture and bleeding with long treatment cycles. A double freeze-thaw cycle, each 8 to 10 minutes in duration, is now currently employed for cryoablation. The following image shows the use of cryoablation in a patient with a papillary RCC. In the first image, we can see a small hypodense solid renal tumor in the right kidney. Then in the next image, we can see B image. 2 needles are inserted in the mass, and then the further subsequent images show a progressive increase of the ice ball after 2 cycles of freezing and thawing. Now about the next modality, that is the radiofrequency ablation. It is the use of radiofrequency energy to heat tissue to the point of cellular death. It uses monopolar alternating current that is delivered directly into the target tissue at a frequency of 450 to 1200 kilohertz. It leads to vibration of ions within tissues, which ultimately results in molecular friction and heat production, which ultimately further leads to irreversible coagulative necrosis and tissue desiccation. In this, the heat is not directly supplied by the probe, but rather by the agitation of ions within the tissue. Small renal masses can be treated with It achieves excellent results in treating exophytic and endophytic tumors both. It is carried out under general anesthetic or conscious sedation. Different types of RFA electrodes could be used. They include the single tip, multi-tined expandable electrodes, or a cluster tip electrode. These electrodes are inserted into the tumor under CT MRI or a ultrasound guidance. If the tumor is adjacent to a bowel segment, we can use hydro dissection also. There are two types of monitoring systems or types of radiofrequency ablation. First is a temperature-based monitoring system, and then there is a impedance-based systems. Temperature-based systems, they work by measuring the tissue temperatures at the tip of the electrode and are based on achieving a specific temperature for a given period. While impedance-based systems measure the tissue impedance at the electrode tip and are based on achieving a predetermined impedance level at the tissue probe interface that indicates complete tissue desiccation. The types of RFA probes include the insulated monopolar probe with 12 deployable tines, the starburst shaped Rita device. Then there is a monopolar system by Covidian. It has a single 17-watch cool tip electrode, which is cooled internally with chilled saline to prevent the charring of tissue adjacent to the probe. The clinical validation studies have suggested more complete necrosis, better lesion accuracy, and superior treatment outcomes with their multi-tine electrodes. Word about the wet radiofrequency ablation probes. They deliver a constant saline infusion into the tissue and in proximity to the probe to lower the temperature of the probe tip. Thus, they lower the charring effect, allowing for larger zones of ablation due to decreased impedance. Bipolar electrodes are not currently preferred because they are less accurate than monopolar systems. About the treatment temperature, the modern temperature-based generators, they reach a target temperature of 90 degrees Celsius to 105 degrees Celsius, and ablation should not be considered successful unless a minimum of 70 degrees Celsius is uniformly reached during the treatment cycle. The impedance-based systems generally reach an ultimate impedance of 200 to 500 ohms. Word about the heat sink effect. It is when the target zone is highly vascularized or is adjacent to large vessels, thermal energy is preferentially dispersed to the comparatively cooler blood within these vessels. So, in this way, the tumor cells are spared in proximity to the large blood vessels, which can lead to treatment failures. So, this is an important thing which should be kept in mind. The temperature-based systems use preferably two separate RFA cycles, which are separated by a minimum 30-second cool-down period. The modality of treatment, these treatments can be delivered percutaneously or laparoscopically. Laparoscopic mobilization of the kidney and accurate dissection of the tumor might provide an excellent exposure of the tumor. It allows treating the anteriorly located tumor safely and avoid injury to the surrounding structures. Laparoscopic approach also allows real-time monitoring of the ice ball formation in cryotherapy and confirmation of the probe positioning as well. The transperitoneal or retroperitoneal way would be depending on the location of the tumor and the surgical expertise. A standard 3-port technique is used. Gerota fascia is incised, kidney is mobilized, and the tumor is identified. The overlaying and surrounding fat might be excised to allow accurate assessment during the treatment. Histological confirmation with an 18-gauge biopsy needle is advocated prior to commencing the therapy. This is a diagram showing the laparoscopic renal surgery. We can see there is a camera port, there is a working port, there is a separate ultrasound port which is used for monitoring, and then there are the potential site for the cryoneedle placements which are given percutaneously under the radiological guidance. Cryoprobes, as I told, are inserted percutaneously under direct vision. Laparoscopic ultrasonography is used to confirm the location of the probes and the margins of the tumor. Treatment is delivered with a double freeze-thaw cycle. After the completion of the treatment, cryoprobes are removed and a low pressure check is performed to check for any post-interventional bleeding. This is another diagram showing the cryoprobes within the tumor, and then we can see the this laparoscopic intraoperative ultrasound which is used to guide the treatment. This is another diagram which is showing the tumor with the cryoprobes inside. We can also see the thermocouples, one at the edge of the tumor and then at the center of the tumor, which are used to sense the treatment generated and also to monitor the ice ball formation. This is another figure which shows a central thermocouple in depth of the center of the tumor and 3 cryoprobes which are placed in a triangle to the base of the tumor. Percutaneous cryotherapy, it can be performed as an outpatient procedure under conscious sedation or general anesthesia. It might offer an advantage to laparoscopic approach, especially in patients which require multiple procedures, such as in the VHL disease. The AUA recommends a renal biopsy prior to ablation to provide a pathological diagnosis and also minimize over-treatment of the benign conditions. In percutaneous cryoablation, patient is positioned in the prone or flank position. Lesion is characterized with CT or MRI. Then the tumor is localized with a finder 20 gauge needle. A representative biopsy is taken with an 18 gauge true cut biopsy needle under CT or MRI guidance. Positioning of cryoprobes and prongs are confirmed, and then the treatment is commenced. Once treatment is completed, cryoprobes are removed, and a very important thing is post-treatment imaging is performed to check treatment adequacy and evaluate for potential bleeding. This is a diagram showing the percutaneous radiofrequency ablation. In the first left uppermost diagram, we can see a patient position on a CT table. Then below this, we can see the probe placement. And then in the upper, we can see the computed the tines deployed. And in the lower right figure, we can see the post-ablation computed tomography picture. This is some figures showing the laparoscopic radiofrequency ablation. First, the tumor is exposed, and then in the lower two diagrams, you can see the probe placement. We can see the tines are deployed, and then in the upper right, we can see the post-ablation appearance of the tumor. About the follow-up, complete loss of contrast enhancement on follow-up CT or MRI is considered evidence of complete tissue destruction and treatment success. A majority of lesions demonstrate a greater than 50% reduction in size in the first year after treatment. Lesions treated with radiofrequency ablation demonstrate a minimal contraction, and they have a distinctive fibrotic halo or circular demarcation around the treatment zone. Enlargement of a lesion, regardless of the treatment modality or any enhancement characteristics, should be seen as a sign of local tumor recurrence. The AUA panel recommends that a CT or MRI scan with IV contrast should be performed at 3 and 6 months after ablation, and then annually thereafter for 5 years. When to do a biopsy post-cryotherapy? If a lesion demonstrates persistent contrast enhancement following the treatment, which denotes an incomplete treatment, or if a lesion demonstrates enlargement following cryotherapy treatment and or new contrast enhancement, which denotes a local tumor recurrence or progression. About the oncologic outcomes, when compared with surgical treatments, CA and RFA demonstrate significantly higher rates of local recurrence, but they can be salvaged with repeat ablation or surgery. There is no apparent significant difference in metastatic recurrence-free survival when comparing these two modalities to each other or against the surgical treatments. Few studies have evaluated the short and intermediate oncological outcomes. Those show that the technical success is around 95.5 to 98.5%. Average need for repeat treatment is around 3%. Small renal tumors less than 3 cm and exophatic location were independent factors for successful treatment. The overall 5-year survival rate reported between 65 to 85%, and cancer-specific survival rate of 8 to around 98%. What are the complications? The risk for major urologic complications is lower with the ablative techniques, that is around 5%, than with either laparoscopic or open partial nephrectomy. There is no significant difference in urologic complications between cryoablation and radiation. Post-operative hemorrhage is the most commonly cited major adverse risk. Bleeding is less common with radiofrequency ablation. Commonly cited minor complications include pain and paresthesia at the probe insertion site, UTIs, damage to surrounding structures, and self-limited hematuria. Possible complications of thermal ablasive techniques are the heat sink effect, thermal injury to neighboring structures such as bowels, ureter, genitofemoral nerve, and psoas major muscle. The post-ablation syndrome, which consists of low-grade fever, pain, nausea, vomiting, malaise, and myalgia, which is mostly self-limited. Then there is infection and abscess formation and acute tubular necrosis and decreased overall renal function. Newer ablation modalities, I have told in a further slide, the name enumerates, I will not do again. A significant study is required to further determine their potential benefits compared with the well-established methods of cryoablation and radiofrequency ablation. One of the modalities is high-intensity focused ultrasonography. When the ultrasound waves are focused with an appropriately shaped transducer, the temperature at the focal point can exceed the threshold for cell death while the adjacent tissue is spared. At sufficiently high intensities, there is a cavitation and microbial formation that yields extremely high temperatures and has a disrupting shock wave, which is seen in the in extracorporeal shock wave lithotripsy. The advantage of this HIFU is it can be administered in an entirely non-invasive or extracorporeal fashion. The disadvantage are the treatment times can be lengthy, as long as 5.5 years. About microwave ablation, it uses the same concept of thermal ablation as the radiofrequency ablation. The electromagnetic spectrum is 900 to 2450 megahertz. The oscillating microwave field, it causes polarization of the molecules, resulting in increased kinetic energy producing heat. It is possible to treat larger tumors with microwave ablation, and because skin pads are not required, therefore the risk of skin burns is also minimal. Irreversible electroporation is another modality where an electric field applied across cells generates the nanoscale pores within the cell membranes that can be lethally irreversible. This is produced through a series of electrical pulses delivered by a single, that is a bipolar, or a multiple, that is monopolar electrodes. This is also considered an investigational treatment at present. A word about the laser interstitial thermal therapy. This treatment modality is currently being evaluated for the treatment of solid tumors, including brain, pancreatic, breast, thyroid, and prostate cancer. It utilizes image-guided low-voltage laser probes to deliver heat and destroy the target tissues. Neodymium yttrium aluminum garnet, that is the ND-YAG laser, has been used to treat small renal tumors. All reports are based on small number of treated patients with short follow-up, and it remains an experimental treatment. About the conclusion, partial nephrectomy remains the optimal treatment for the management of small renal masses. Over the last few years, focal ablative therapies like radiofrequency ablation and cryoablation have emerged as an alternative option to the extraoperative surgical treatment. Focal ablative therapies represent a valid treatment option, especially for high-risk patients, especially in elderly and those with comorbidities. Ablative techniques seem to result in favorable complication rates and approach oncological and functional efficacy equivalent to partial nephrectomy in small renal masses. So, focal ablative therapies are a feasible renal sparing intervention for the management of RCC in appropriate patient candidates. Thank you so much, sir.
Thank you, Arnav. That was an extremely nice presentation, and you finished in time. We have 2 minutes for discussions. So, is there anyone who would like to raise any questions here? And to start off, I would like to ask Arnav if which are the cases? This is obviously a very attractive treatment. If you get a patient with a small renal mass and you tell him, just summarize for us, which are the patients where it should not be done?
Sir, any like renal mass which does not come in the CT1A category, sir. Above than that, we should not use these focal ablative therapies, sir. And also like those who are like good candidates, surgical candidates, those also patients, we should not go for focal ablative therapies. Rather, we should go for a surgical extraoperative treatment, sir.
A patient with a Bosniak 4 cyst, would you apply this treatment?
Sir,
the dangers.
Sir, cystic renal masses generally, like the literature says that we should not go for a focal ablation therapy, sir. Better to go for a like other surgical treatments rather than going for a. This is like a relative contraindication for a focal ablative therapies, the cystic renal masses and the hilar masses. Sir. So we should not go for like a focal ablation therapy, like for a Bosniak 4 cyst.
May I request any of the faculty here, or many of them, there are many senior, so do you have any experience of this treatment in this country? Shivajida, any patients under your care been treated, and what's your follow-up?
I'm trying to unmute myself. Yes. Yes, we have done about 14 cases at Fortis Hospital. Really small masses, but actually we have gone to 4 to 5 centimeter mass as well, which was not the, but it was a very frail patient. There was no other choice. But there was a mixed reaction, and most of them were lost in follow-up. That's the problem with this system. And can I ask Arnav about any role of preoperative biopsy? I missed, maybe I have missed that part. Preoperative biopsy to characterize the papillary or clear cell carcinoma before we go for the cryoablation therapy.
Yes, sir. The AUA guidelines panel, they strongly. Sir, the AUA guidelines panel, they strongly recommend that prior to the any kind of these focal ablative therapy, should go for a renal mass biopsy to characterize the lesion according to like the histologic type also, and to prevent the over treatment of the benign condition. So yes, sir, it is actually required to do a renal mass biopsy prior to commencing any of these ablative therapies.
So which lesion will you go for it? And which lesion you would refrain from?
Sir, the small renal masses, that is the clinical stage T1A, mostly
no, I'm talking about the papillary or the clear cell.
That the only two studies, like it has been mentioned in the EAU guidelines also, that the results have been good for the papillary renal cell carcinoma in compared to the clear cell renal cell variant. So if possible, it's better to go for the these therapies in the papillary renal cell carcinoma variants.
Thank you.
Okay. So anyone else in our faculty team who would like to make a... Yes,
sir. I would like to ask one question, sir. This is Anshuman.
Good evening, sir.
Yes,
please.
You talked about laparoscopic guided ablative therapies. Now, if a patient is fit enough to undergo laparoscopy, would you prefer a laparoscopic partial nephrectomy or a laparoscopic guided ablative therapy in such a patient?
Sir, actually, the focal ablative therapies are not available in all settings, sir. So basically, like in normal sir institutes level, sir, we will go for a laparoscopic partial nephrectomy itself only in those institutes which have the instruments available and also the expertise available, or then only we will go for those. But normally, sir, we will go for the laparoscopic partial nephrectomy if the patient is especially fit enough.
Okay.
Okay. Can I have one question, sir? Yes, sir. Can you detect what type of any treatment modalities are available in India? Do you have any idea?
I think, sir, not much, but sir, cryotherapy and radiofrequency ablation are mostly, sir, I think available in like big institutions.
I think radiofrequency ablation, Samir, is available at least in Kolkata in several centers. Sir. Many people are doing it. And and cryoablation has come up very, very recently. So I think after the pandemic, I think there's going to be a huge explosion now that people are coming up for treatment. New technologies will develop. And increased detection of small renal masses, I think these are real options in treatment. So I think we've had a nice discussion. I think Dr. Harpreet has a question or a statement that focal therapies for people who can't undergo surgery or definitive therapy, which I think is absolutely correct. But they are also very attractive to people with very, very small renal masses. When it's a toss-up whether you've got a 2 centimeter enhancing mass and what to do. It's a difficult decision. But I think let us proceed to the next presentation, which is going to be equally relevant and interesting. And that Dr. Ajit,
yes, sir.
He's going to talk on metastatic renal cell carcinoma, the current status of management. So let us proceed. We are still almost on time, running 5 minutes late.
Should I share my slides, sir?
Please do.
Okay, sir. I'm sharing my slides, sir. Is it visible, sir?
We haven't seen your slides. We haven't seen your slides. Shall we ask the organizers to share the slide?
I think
yes, sir, I will share myself.
I'm not disabled yet. Multiple sharing.
Yeah, we can see you.
Is it visible, sir?
Yes.
Yes, please.
Good evening, teachers, my seniors and colleagues. Myself, Dr. Ajit Gupta, DNB PDT 3rd year from Fortis Hospital, Kolkata. Today, my topic of presentation is current status of management of metastatic renal cell carcinoma. Approximately 1/3 of all patients with newly diagnosed renal cell carcinoma are seen initially with synchronous metastatic disease, and another additional 20% to 40% of patients who presents with clinically localized disease at diagnosis will eventually develop metastasis. Metastatic RCC is almost always fatal with 10-year survival rates of less than 5%. synchronous metastasis detected at presentation have worse outcome, with many patients dying of disease progression within an year. Patients with metastatic renal RCC are stratified into 3 groups. Those are favorable, intermediate, and poor risk groups on the basis of MK adverse prognostic factors. We know 2 types of risk stratification. One is MSKCC and the other one is IMDC. In the risk adverse prognostic factors included in MSKCC groups are Karnofsky performance score less than 80%, serum level of LDH is more than 1.5 times upper limit of normal, hemoglobin level less than lower limit of normal, and corrected serum calcium is more than 10 milligram per DL, and there is absence of prior nephrectomy. Those patients having adverse prognostic factors without any adverse prognostic factors are placed in favorable risk group, and the median overall survival of these patients are predicted to be 20 months. Patients with adverse prognostic factors with 1 or 2 factors are placed in the intermediate group, and the median overall survival for these patients are predicted to be 10 months. And patients having 3 to 5 adverse factors are placed in poor risk groups, and the median overall survival is predicted to be 4 months. Coming to IMDC prognostic factors, this includes 6 factors, which is Karnofsky performance score of more than 80%, hemoglobin is less than lower limit of the normal, thrombocytosis, neutrophilia, elevated corrected calcium level, which is more than 10 milligram per DL, and less than 1 year from diagnosis to VGF targeted therapy. Here again, with the patients with without any prognostic factors are placed in favorable group, and here the median overall survival is 43.2 months. Patients having 1 to 2 adverse factors are placed in intermediate risk groups with median overall survival of 22.5 months. Patients having 3 to 6 adverse prognostic factors are placed in poor risk groups, and the median overall survival for these patients is 7.8 months. Coming to the management of metastatic RCC, there are...
Not audible clearly. Please take care.
Okay, sir. Coming to management of metastatic RCC, the first is surgical management. The second is systemic therapy. For those patients who are not fit for surgery, they can go for embolization of the primary tumor. In the group of surgical management, we can go for debulking or cytoreductive nephrectomy, resection of metastasis, and palliative surgery. In systemic therapy, we can go for immunological therapy or targeted molecular agents, which can be antagonist to the VEGF pathway, tyrosine kinase inhibitors, or newer VEGF receptor-based targeted therapy, or inhibitors of mTOR. Coming to surgical management of metastatic renal cell carcinoma, the first is debulking or cytoreductive nephrectomy. Tumor resection is potentially curable only if all tumor deposits are excised. For most patients with metastatic disease, this cytoreductive nephrectomy is palliative, and systemic treatments are necessary after debulking of the primary tumor. And this cytoreductive nephrectomy is must before any immune therapy, but it is not required before application of targeted therapy. This Carvina trial, which compared the cytoreductive nephrectomy followed by sunitinib in one arm, and in the other arm, sunitinib alone was given. This was a phase 3 non-inferiority RCT. This showed the median overall survival in the nephrectomy arm along with sunitinib was 13.9 months, while in the sunitinib alone was 18.4 months. There was no significant difference in recurrence rate or progression-free survival. The best results were seen with low volume pulmonary mets with good performance score and absence of atypical histology like sarcomatoid or collecting duct or medullary carcinoma histology. Dissection of metastasis. Most patients with metastatic RCC will not achieve a cure or long-term disease remission with currently available systemic agents. Resection of isolated metastatic lesions is a reasonable and widely employed practice in well-selected patients with RCC, and the favorable prognostic factors are age group, those patients with less than 60 years of age, presence of a solitary metastatic lesion, pulmonary mets or tumor size of less than 4 centimeter, and the disease-free interval of more than 1 year, and metachronous lesion. Now, coming to local therapy of RCC bone metastasis, metastectomy and curettage of the RCC bone mets, and which is followed by local stabilization of solitary RCC bone is indicated, or single dose of IGRT with equal to or more than 24 Gray had a significantly better 3-year accurate local progression-free survival rate. On the basis of pain relief efficacy and durability, time to pain relief and duration of pain relief were similar for single-dose stereotactic body radiotherapy and the conventional radiotherapy. Coming to local therapies for RCC bone metastasis, the stereotactic radiosurgery versus whole brain radiotherapy versus combination of these two, stereotactic radiosurgery with whole brain radiotherapy, the 2-year overall survival and intracerebral control were equivalent in patients treated with SRS alone and SRS plus whole brain radiotherapy. And both treatments, when was combined, they were superior to the whole brain radiotherapy alone. Coming to embolization of metastasis, embolization prior to resection of hypervascular bone or spinal metastasis can reduce intraoperative blood loss. In selected patients with painful bone or paravertebral metastasis, embolization can relieve symptoms. Palliative surgery, cytoreductive nephrectomy can be performed with palliative intent in patients having intractable pain, intractable hematuria with constitutional symptoms, and paraneoplastic manifestation in the form of hypercalcemia, erythrocytosis, secondary thrombocytosis, and hypertension. Patients who may benefit from non-curative resection of metastatic lesions, those include with having solitary brain metastasis or metastasis lesion in weight-bearing bones or joints, vertebral metastatic lesions with impending spinal cord or radicular compromise. Surgical resection is often combined with radiation plus minus systemic therapy in many of the above situations. In patients, those who are unfit for surgery or with non-resectable disease, embolization can control symptoms, including visible hematuria or flank pain. Coming to the systemic therapy of metastatic clear cell RCC, the first is chemotherapy, which is generally it is ineffective in the treatment of RCC, but in case of sarcomatoid histology, if performance score is good, gemcitabine and doxorubicin has shown some good effect. This can also be offered in rare patients with the exception of collecting duct and medullary carcinoma, and in these patients we can go for gemcitabine plus carboplatin. Coming to immunotherapy, initially interferon alpha was used as monotherapy, but for this the overall response rate was approximately 10 to 15%, but the durable complete response rate was very low and it was less than 2%. But when it was combined with bevacizumab, the response rate went up to 30%. But the advent of targeted therapy in clear cell metastatic RCC, interferon alpha has been superseded. Coming to interleukin-2, this it was started for treatment of metastatic RCC in the year of 1985. The response rate ranges between 7 to 27%, and the high dose of interleukin-2 was approved by US FDA in the year of 1992 for metastatic RCC. The dose was 6 to 7.2 lakhs international unit per kg. It was given every 8 hourly for a maximum dose, 15 doses, and it was given in IV intravenous bolus dose. Total 4 cycles were given, and each cycle consists of 2 treatment sessions. The gap between 2 treatment sessions was made to be 10 days. This caused considerable toxicity like vascular leak syndrome, which resulted in third space fluid retention, respiratory compromise, and multi-organ damage. The other toxicity were hypertension, fatigue, diarrhea, and hand-foot syndrome. High-dose intravenous interleukin-2 remains a reasonable option in the initial therapy of carefully selected patients with metastatic RCC in case of inability of newer target agents to induce durable response. Once allogenic hematopoietic stem cell transplantation was used to treat metastatic renal cell carcinoma, this allows the replacement of host or recipient immune and hematopoietic systems with those of a healthy HLA-compatible donor. Transplanted donor graft generate an allogenic anti-tumor immune response, which is known as graft versus tumor effect. This was associated with a variety of adverse events, which was typically associated with the conditioning chemotherapy in the form of pancytopenia, a variety of opportunistic infections, and graft versus host disease. This has no longer been explored as a variable therapeutic approach in RCC. Coming to immune checkpoint blockade, over the last few years, it has become increasingly evident that several inhibitory receptors on effector immune cells, such as CD8 plus T lymphocytes, they play a key role in tightly regulating the immune response to tumors. And anti-tumor response can be downregulated by activation of T cell responses, such as cytotoxic T lymphocyte associated antigen, that is CTLA4, and those mediating programmed cell death, that is PD1. And more recently, PD1 and its ligand, PDL1 and PDL2, have attracted attention as potential anti-tumor targets. PD1 is expressed on T lymphocytes, while PDL1 and PDL2 receptors are expressed on the surface of tumor cells, macrophages, and other cells. Those patients whose tumor contain PD1 positive tumor infiltrating lymphocytes are more likely to have larger tumors. They have high grade. They present with advanced stage of RCC, and they might have sarcomatoid differentiation. Coming to immune checkpoint inhibitors, ipilimumab, this is CTLA4 inhibitor. This is effective even in progressive disease, those patients who have progressed even after IL-2 therapy. The dosing schedule is 1 milligram per kg of body weight. It is given intravenously thrice weekly, 3 weekly. The side effects are enteritis, thyroiditis, autoimmune disease. This nivolumab and pembrolizumab are PD1 inhibitor antibody, and atezolizumab and avelumab are PDL1 inhibitors. Coming to targeted therapies, the molecular basis of targeted approach in clear cell renal carcinoma, the VHL gene is tumor suppressor gene with single hit, and there is mutation. There is disruption of VHL complex, and which leads to increase in the concentration of hypoxia-inducible factor, which further causes increase in the level of VEGF, PDGF, tissue transforming growth factor alpha, which causes neovascularization and helps in the stabilization of the angiogenesis, and hence enlargement of the tumor and its survival. Targeted molecular agents in clear cell RCC are antagonists to the VEGF pathway, tyrosine kinase inhibitors, and VEGFR receptor-based targeted therapies, and inhibitors to mTOR. Coming to monoclonal antibody against circulating VEGF, bevacizumab. This was first VEGF pathway antagonist used in clinical trials. This is humanized monoclonal antibody against VEGF-A. This was very well tolerated, and the response rate was approximately 10%. But when it was combined with interferon alpha, there was higher median progression-free survival for those patients who were treated with the combination group, and the overall toxicity was greater for the combination group, with significantly more grade 3 like hypertension, bleeding, anorexia, fatigue, and proteinuria. Coming to tyrosine kinase inhibitor, sorafenib. This is an oral receptor multi-kinase inhibitor, currently infrequently used in the first line setting, but it is commonly used in patients whose disease progressed on sunitinib or similar drugs. Sunitinib. This is an oral VEGF receptor kinase inhibitor. This is widely used until recently in the initial treatment of metastatic clear cell RCC. This is a potent inhibitor of VEGF receptor 2, PDGF receptor beta, and c-KIT FMS like tyrosine kinase 3. It is given in the dose of 50 milligram per oral OD 4 weekly, followed by 2 weeks of gap. The overall response rate was approximately 31%, and the progression-free survival was median of 11 months. This is contraindicated in uncontrolled hypertension or cardiovascular disease or any cardiovascular events occurred in previous 12 months or in case of brain metastasis. The side effects are hypertension, fatigue, diarrhea, hand-foot syndrome, pancytopenia, and hypothyroidism. After the initiation of sunitinib, after completion of the 2 cycles, the patient is reviewed and the therapy is continued only if one of the below mentioned criteria are met. If the disease is stable and if there is clinical benefit, if there is symptomatic improvement, or if there is partial or better response of the therapy. In case of the progression of the disease, the therapy is discontinued. Thyroid function test should be done every 2 weeks of the cycles. Currently, sunitinib is largely used in the treatment of good prognosis patients or those unable to receive checkpoint inhibitor-based therapy. Coming to pazopanib, this is selective. It has selective activity against VEGFR family and were evaluated as a possible means of diminishing the side effects associated with therapy without compromising efficacy. It is potent inhibitor of VEGF receptors, but also it retains activity against PDGFR. The toxicity were mild with very few 3 and 4 grade 3 and 4 adverse events, but it is very highly hepatotoxic, so it is contraindicated in patients with hepatic impairment. In COMPASS trial, which was done to know the efficacy and safety of pazopanib with respect to sunitinib, it was non-inferior to sunitinib as first line of for clear cell RCC. In PIECES trial, which was done between pazopanib and sunitinib on the for the patient preference basis, which showed that 70% of the patients preferred pazopanib, while only 22% preferred sunitinib. Coming to axitinib, this is highly selective oral small molecule tyrosine kinase inhibitor. It benefits in patients showing progression to sunitinib. Its dose is 5 milligram per oral BD. In ACCESS trial, which was shown for progression-free survival, in axitinib comparative comparing sorafenib and axitinib with significant showed the significantly longer progression-free survival. Now coming to newer VEGF receptor-based targeted therapy strategies, cabozantinib inhibitor and has activity against VEGF receptor, MET and AXL. This is associated with significant toxicity. Most patients were managed, most patients presented with toxicity were managed with dose reductions, and only 10% of the patients required permanent discontinuation because of toxicity. In METEOR trial, which was done cabozantinib versus everolimus in patients with VEGF and VEGFR failure, this established the cabozantinib as a reasonable option in patients who had received a prior angiogenesis inhibitor. Based on these data, the FDA expanded the approval of cabozantinib to include patients with untreated advanced RCC. This is levatinib with it has additional inhibitory activity against fibroblast growth factor receptors. In combination with everolimus, it is approved for use in patients who have progressed on prior anti-angiogenesis therapy. Coming to mammalian target of rapamycin inhibitors, everolimus is an oral mTOR inhibitor. Its dose is 10 milligram OD. This is established in the treatment of VEGF refractory diseases. It appears to play a role in regulating translation and stability of hypoxia-induced factor 1 alpha. Temsirolimus, this was approved by the FDA for the treatment of patients with
you will have to make yourself a bit brief now because we are running short of time. Okay.
Yes, sir. Yes, sir. Coming to sequencing systemic
and
therapy.
I have a request. Please talk to the current status, not what I know about it. You must talk to the current status. That is your topic.
Yes, sir. Coming to sequencing systemic therapies in clear cell metastatic RCC, the sequencing of targeted therapies is established in metastatic RCC and maximizes outcomes. The first line in keynote trial, it has been shown that pembrolizumab and axitinib or nivolumab and ipilimumab, which was shown in Checkmate 1/4 trial, these are the new standards of care for frontline therapy. At progression after the axitinib plus pembrolizumab combination, this can be changed to VEGFR TKI, which is recommended, and cabozantinib or any other TKI, which is not previously used. Use of mTOR inhibitors are only indicated when there is VEGF targeted therapy is contraindicated. Cabozantinib is the only agent in VEGF refractory disease with a survival advantage in an RCT and should be used preferentially. Coming to non-clear cell metastatic RCC, there is no phase 3 trials of patients with non-clear cell MRCC. Studies suggest that outcome of these patients with targeted therapy is poorer than the CC-RCC. The most common non-clear cell subtypes are papillary type 1 and non-type 1 papillary RCC. Subset analysis have shown impressive results for PD-L1 inhibitors combined with CTLA4 or VEGF targeted therapy in renal tumors with sarcomatoid features. This is the updated European Association of Urology guidelines, which is recommended for treatment of first line and for clear cell metastatic renal carcinoma, those patients who are treatment naive. For those patients who are under favorable risk of IMDC category, the first line of treatment is pembrolizumab plus axitinib. If patients who cannot receive or tolerate immune checkpoint, they can be given sunitinib and pazopanib. Patients with coming under intermediate or poor risk IMDC, we can start with pembrolizumab plus axitinib or ipilimumab plus nivolumab. If this is not tolerated by the patient, we can go for cabozantinib, sunitinib, or pazopanib. In patients who have already received any kind of immunotherapy or TKI therapy, the standard of care for the patient who have received immunotherapy, we can go for VEGF targeted therapy, which has not been used previously. And patients who have received TKI, they can be given nivolumab or cabozantinib. And in case of intolerability, we can give axitinib. Thank you, sir.
Okay, thank you, Ajit. This was a difficult topic, but I think the crucial aim should have been to identify 2 points. Which are the patients, identify the risk categorization of these patients, what are the indications for cytoreductive nephrectomy and case selection for cytoreductive nephrectomy, and the new standards of care for first-line therapy, which is either TKIs with anti-PD-1 inhibitors or anti-PD-1 with anti-CTLA4, basically immuno-TKI and immuno combinations. But I think you made a very good effort, but it's a difficult topic to present very briefly. And I think Dr. Ashu has a set of MCQs. The MCQs are all dedicated to metastatic RCC. So there's plenty of opportunity, and there's a case tomorrow. So we'll just proceed directly to the next presentation, which is by our very senior faculty, Dr. Samir Swain. But he will discuss on the steps of radical nephrectomy. May I request Dr. Swain to take
Yes, yes, sir. Good evening, sir. Hello, am I audible,
yes.
sir?
Yes, yes.
Yes.
Please share your screen.
Is it visible, sir?
Yes.
Yeah. Good evening, all. We had a very good discussion regarding very basic points in management of renal cell carcinomas. So my topic is to go through the steps and states of radical nephrectomy. So what are the principles and requirement for the surgery? It is thorough evaluation of the patients, counseling, whether you are planning for open surgery, laparoscopy surgery, or robotic surgery. Next comes the patient characteristics, obese patient, short stature patients. It has to be a predetermined to the port position in case of laparoscopic and incision in case of open surgery. Why I'm telling all these things? Because majority of us almost have exposure in the resident level through open surgeries. And nowadays, almost every center is doing laparoscopic at least. So, and the detailed study of imaging before going to the surgery is very important. It characterization of the location of the tumor and its correlation with the body habitus, so that we can plan our exact port position regarding camera port and secondary ports. And specifically, we must go through the CT angio to ensure the relationship of the vessels to the mass as well as to the hilum, so that our next level dissection inside will be quite easier. But many times it so happens that there is a variability, and once there is a variability, when you found on table, it may be lap and case of open, then you must search for another abnormality, because one congenital abnormality in kidney, there is a possibility of multiple abnormality. And next, coming to the position of the patients, then instruments, and in case of laparoscopy, endovision system and energy sources and rescue measures. All these points has to be kept in mind before going directly to the surgery. Endovision system should be best. All type of energy sources should be available to tackle the difficult situations. Position of the patients is actually it depends how we are planning the surgery. Another point is to know how we are well versed with the situation. Suppose in case of open surgery, we are planning for simple, maybe small renal mass. In case of left side, we can go for flank incision, or else we can go for shuttering incision, or sometimes in case some are preferably using midline incisions. Similarly, it's in case of right side, flank incision, again shuttering incision or midline. But in case of IBC thrombus, we must go for midline surgery. But frankly speaking, hello, am I audible, sir?
Yes, you are audible.
Yeah, but frankly speaking, I don't have any videos in the open surgery, so I am directly going to the video presentation of left side. This is one image I got from the net, and I thought I should share this image. It shows the typical left side port position, and the incision line shows the expected extraction incisions. So coming to the procedure, I am showing one difficult case. Means it's not difficult, but it may be a case which is maybe a medium-sized T2 type of tumor, and along with multiple perirenal adhesions, and maybe maybe it's a lymph node, few lymph nodes. So let's see. Is my screen visible, sir? Hello?
It's blank. Now
Okay.
it's visible.
Okay. So this is the laparoscopic left radical nephrectomy. Initially, the peritoneum is to be incised, and initial point is to go all up to the splenic mobilization. It should be done as maximum as possible in cephalad direction. Initial exposure and initial localization of the renal mass is important, so that our next dissection will be easier. And lowermost point to be dissected, it should be up to the pelvic bridge. And this is the point where we will search for Schwarz window. This point is really difficult in many cases or initial cases. Exact position and exact psoas window localization is crucial for any kidney surgery. So this is the position of the psoas window. Then we can see easily the psoas muscle. Next point is to have a good window, and we can, so that we can have a good control over the lower pole of the kidney, because this is a fairly large mass of around 8 centimeter mid and lower pole location. Next point is to search for the hilum. I usually use maybe hook or ligature or maybe harmonic. Any energy source is okay, but one must be careful and must be knowledge enough to deal with all the energy sources. Now we can see the renal vein. Now we are trying to localize the gonadal. And in all case of kidney surgery, we must search for any abnormality. This is lower psoas window mobilization up to the hilum. Now we can see the lumbar branch. This is most important point during kidney radical nephrectomy, because this is the, if the lumbar vein is injured, then it is very difficult to tackle the on this situation. So careful dissection. And we can see in this video there are a lot of lymphatics and perirenal adhesions. I'm categorically choosing this type of case because probably in all centers, EG cases are easily done. So I thought I must give some sort of situation where we usually face little bit of difficulties. So initial mobilization of the lumbar, then careful dissection throughout hilum to localize the vein, and will at the same time we'll try to localize the renal artery. In this case particularly, the adrenal vein is quite low down, though it is not common. Usually adrenal and gonadal, the venous insertion level is almost similar level. But this case, the adrenal was quite low down. So I categorically and intentionally not dissected the adrenal to avoid low down dissection. Now you can see with gradual dissection through energy source or through the suction, we have to identify the main renal artery. In this case, there is single renal artery, but in many situations there are usually accessory artery. It's a common mistake from any imaging modalities. And my principle is to initial dissection of the artery, and I usually give one clip so that the kidney size will shrink, further dissection will be easier, and at the same time the chances of blood loss is less. Next, I don't divide the artery, and at this point of time, usually next level dissection is to be on the vein, so that vein to be dissected or inside it should be tackled first, then gradually next level will tackle the artery. Because this is a case where there is lot of perirenal and hilar adhesions and probably lymph node positive, though I definitely not tried to go for lymph node dissection, and it's not recommended also. Exact placement of clips, Kimolog, and maybe Liga clip is important. There should be definitive gap in between, and the incision should be given part by part. It should not be complete at a time, or it should not be at a single stage. Next, dissection around hilum to clearly demonstrate the renal artery. Like you can see, these dissections are quite easier when the mass is quite small. Since nowadays almost smaller mass are tackled with partial nephrectomies, so usually for radical nephrectomy, these type of situations are quite common. So that's why I was interested to show a little bit difficult cases. Now you can see the Hemlock clip is placed well, though there are a lot of controversies regarding Hemlock clip and placement of Liga clips. Sometimes I prefer multiple Liga clips and one Hemlock, or maybe two Hemlock and others. But this just as surgeon's preference, nothing hard and fast rule. But it should be, all clips should be placed properly. All clips should be placed in with a difference of space, and there should be gap between the incision of the vessel. Now gradual dissection through the hilum and mobilization of all the kidney to be done. And exactly the kidney should be mobilized beyond the aorta. This is the case, this is the mass of mid and lower pole mass. So we'll try to go all around the kidney along with the aorta. Now lower part of Schwarz window to be dissected clearly so that ureter can be divided. Though the length of ureter to be tackled is not clear, but it's preferable to go as low as possible. And subsequently, we can manage to deliver the kidney with complete dissection all throughout. Many situations we can go for even harmonic or ultrasonic scalpel or vessel sealer can be used to tackle the small veins like gonadal or adrenal or even ureters. There is no need of clipping because the size of ureters and all are almost manageable with this energy sources. And in case of non-refluxing system, it's also not mandatory to go for the clipping of the lower part. Many times there are situations where we usually don't not able to get any space, or it's very difficult to get into the hilum, or many times the vessels are not clear or as per the expectation of the imaging system. So in this type of difficult situation, there are newer modalities available where we can plan the surgery and we can keep the methods to delineate the vessels. So this is indocyanine green. That is a method that is usually useful in delineation of vessels. In that IV injection is given so that with absence of light, we can easily see the exact. Now we can see the initial veins. Now a renal vein is clear. And in difficult situation, this is for a demonstration only. In difficult situation, this will be helpful to know the exact location of the vessels so that careful and confident dissection can be done. And by that way, you can avoid many havoc or unnecessary conversion to the open surgery. In particularly ICG, the initial injection and searching for vein is to be very low. Otherwise, usually what happens with time, the dye usually spreads all over and gradually it's difficult to identify the veins and major vessels. So it should be the dissection and searching should be done earlier. So coming to the right side, this is the typical port position on the right side. I usually go for 3 port and sometimes assistant ports if required. And this port is for liver retraction. The port position exactly depends as per the patient body habitus, and second is as per the location of the tumor. And though I have gone through all the steps in right side, I will be giving few special points where we can tackle the right side RCC cases to be managed easily. Now this is the case where there is a right side renal mass occupying the lower and mid pole of around 8 to 10 centimeter. Initial dissection to be done, mobilization, coagulation of the bowel. Specifically, that this dissection is important just to avoid injury to the duodenum. And most important issue and most important point of right side radical nephrectomy to identify and establish control over the IVC, and you must delineate what is exactly the IVC location, what exactly the presence of mass, and what exactly the presence of expected veins, and what should be our window. In this image, the blue lines are the renal vein and IVC, green lines are the windows for dissection, and the red line is showing the expected location of the artery. And our dissection should be confined to either lower pole or upper pole, or make a window on both sides. That depends on the surgeon preference, and it depends on the location of the mass. Suppose the mass is small enough, maybe 4 to 5 centimeter, and located on the lateral aspect of the kidney. In that condition, any dissection is okay. Suppose preferably the mass is present in the upper pole, then maximum benefit will go, or the dissection will be easier when we approach to the lower pole and avoid creating window from the upper side. Because in that situation, usually the vessels are pulled down. These are placed lower one. So next level is to dissect around the hilum. We can create window on both sides, and gradually the artery and veins are to be managed with clips. And in the right side and left side, the difference is the left side we can directly go to the hilum, but in the right side you must have a very good control and identification and realization of the IVC and its relationship to the renal vein and the tumor. Now I am showing one second case where the right side again, there are multiple veins. Usually the right side kidney, right side radical nephrectomy is sometimes challenging because the chances of converting to the open is quite more as comparison to left because of shorter vein and approximation to the IVC. And many times the dissection around IVC and renal vein, there are tear and there are small injury to the IVC or maybe renal vein or maybe gonadal. So if there are multiple renal veins, when we know beforehand through imaging, usually it's a very typical situation when there are two arteries, usually vein remains in between, or if there are two veins, usually the artery remains in between. Usually, but it's not a fixed rule, but many times if imaging shows two veins, usually we can go and search the artery in between if it's not clearly seen in the imaging. This is the clue where multiple vessels are available or we know beforehand. But I must point out that even if there are normal anatomy or single vessel, but still we must expect multiple anomaly, particularly artery or veins in kidney. And this is case, Sarah has told me to show me some lymph node dissection. So this case is locally advanced RCC with a definitive lymph node. Now you can see the lymph node is sitting just over the hilum, almost opposing to the IVC and renal vein confluence. So here the dissection should be more careful and more meticulous, just to avoid the when other energy sources should be avoided. Hook is the best one, or sometimes we can go with maybe suction. Small tear, if happens, we can just put a gauze piece so that it will be closed automatically with the due course of our surgery. The lymph node dissection has to be done properly because hilar lymph nodes dissection and without hilar lymph node excision, the hilum management is quite difficult. The lymph node dissection in this type of cases is to be done just to approach the hilum or for documentation point to have a histopathology. But though there is no clinical benefit to go for typical lymphadenectomy, so exactly this is not required. So lymph node dissection and further completion of surgery is to be done. Now we can identify the vessels clearly, both artery and veins. And particularly if lymph node is present in the hilum, it's really difficult to dissect around. And there is possibility of injury to the vein. So in this case particularly, I have used Satinsky, lab Satinsky, to control the artery initially, to decrease or to minimize the size of the kidney, so that next level dissection will be easier. Then next, control of vein and control of artery, because artery is usually below. So once the vein is dissected off, the next level dissection to the arteries will be easier. So ultimately, whatever the dissection and everything is done, my suggestion is to go with each and every steps, starting from the patient's positioning, starting from the availability of endovision system as well as energy sources, meticulous dissection around the hilum, and particularly the dissection in case of difficult situation, there should have low threshold to convert to the open. And specifically, I must tell one point regarding positioning of the patients. In case of laparoscopy, many times not required to go for kidney bridge, but in case of open, it's definitely required, but not in midline incision cases. And in case of position of the patients as regard the table, the open position in case of flank or maybe chevron incision, the patient should be at the edge of the table towards the surgeon. But in case of laparoscopy, since we are operating on the opposite side, the abdomen should be on the edge of the surgeon, so that next level dissection and maneuverability of the instruments are quite easier. Thank you, sir.
Thank you very much, Dr. Sameer, for your very detailed presentation. And I think, I'm sure this was helpful. I think there will be many questions, but if there's any question for Dr. Sven, like we can take it now, or there will be an opportunity to discuss it tomorrow when he takes his classes. So if there are no other questions, we may ask Dr. Debango Sarma to please proceed with his presentation.
Good evening.
Thank you.
Thank you. Thank you, Dr. Sven.
My respected teachers, seniors, and students. So today I will be presenting on the steps of partial nephrectomy. So am I visible, sir?
Yes, you are.
So what I'm going to cover today. So I'll be covering the steps of partial nephrectomy that will be both open as well as laparoscopic. Now, as we all know, the steps of open as well as laparoscopic are almost similar, except the positioning and the incision in case of open and ports in case of laparoscopy. So I will be discussing both open as well as laparoscopic one. Next, I will be presenting two videos, small videos, one of partial right as well as another of partial left-sided nephrectomy. That will be a laparoscopic one. So starting with the positioning in open partial nephrectomy, we have two positions, right? So first is supine position and second one is lateral decubitus with kidney bridge. Now supine position, when we use it, it is usually good if it's a right-sided tumors, because IVC will be lying in front of us. And as we all know, right renal vein is shorter. So it will be, the hilum will be in front of us. Lateral decubitus with kidney bridge, yes. Why it is better? So that we can access the retroperitoneum in a direct way, and in posteriorly located tumors, it's good because we can flip the kidney more easily in case of a lateral decubitus position. Now, what are the types of incision that we can use in an open surgery? So first is in supine position, we can have three incisions. One I have intentionally left, that is the midline one.
First one is subcostal or the coccus incision. Second is sevron incision, which is rarely used in case of a partial nephrectomy. Yes, for radical nephrectomy, we can use a sevron for a very big mass, right? Now, in flank positions, we can have various types of incision. It can be a thoraco-abdominal one, again, which is very rarely used in case of partial nephrectomy. It's usually used in radical nephrectomy. Then we have a supracostal incision or costal incision that is at 11. Then we have a transcostal non-rib cutting incision between 11 and 12 intercostal space. We have a subcostal that is below 12. And we have a Foley's muscle splitting incision, which we usually don't use in case of a kidney surgery. Now, these are the incisions which we use. So on the left side, this is the coccus that is on subcostal incision. Sevron, if we extend it to the other side, then we have a Mercedes-Benz incision. This Mercedes-Benz and Sevron we usually don't use in a partial nephrectomy. Then what I told about the flank incision, that is the supracostal, transcostal, as well as thoracoabdominal, Foley's muscle splitting, and flank subcostal incision. Now, what are the advantages of various types of incision? In case of an open surgery, subcostal incision is that we give in a supine position. It is transperitoneal where we reflect the colon. So as I told already, in right-sided tumor, the IVC lies in front of you in case of a transperitoneal subcostal incision. So the access to the hilum is easy, as well as IVC is easy on the right side. In flank incision, that is lateral decubitus, it is good for a left-sided surgery, left-sided kidney surgery, because the access to the artery is very good. Because if we go posterior to the kidney, we'll directly approach the artery. And second thing is that already I have told that the direct access to the retroperitoneum is very good. And it is good for posterior located tumor. Even on the right side, if the tumor is located posteriorly and you want to incise it, then you don't have to flip it. You just have to dissect the posterior side and you get the tumor directly. So these are the advantages of various incisions in open surgery, right? Now, what are the operative steps? Now, from here, the steps of both laparoscopic as well as open is almost same way. In one, we are using our hand, other we are using the instruments, right? The first thing in transperitoneal one is medialization of the colon. So medialization of the colon is always done in the line of the Toldt. In the line of the Toldt, the avascular line, we mobilize the colon downwards medially, inferior and medially. Then we enter the retroperitoneum. That is how we enter the retroperitoneum directly, right? Now, second thing, on the right side, we do cauterization of the duodenum, already shown by Dr. Samir. Then we do the hilar dissection. Now, in partial nephrectomy, hilar dissection can be done in two ways. One is absolute skeletization of the artery and vein separately, and second is en bloc dissection of the hilum. When we do a skeletization of artery and vein, it is one advantage is there, so that in case of any untoward event that may happen during surgery, we can go for a radical nephrectomy as soon as possible, because our artery and vein is there only. And many of the people, they don't dissect the artery or vein separately. They do an en bloc dissection by making two windows. The famous two windows technique. One is in the psoas and one just superior to the hilum. So these are the two ways how we can do a hilar dissection, both in open as well as laparoscopic surgery. Now, second, then after dissection of the hilum, there comes the dissection of the tumor. What is dissection of the tumor? We localize the tumor. Then we dissect the perinephric fat in and around it, but not over the tumor. The margins, the main aim of the dissection of tumor is that the margins of the tumor should be clear. It should be very clear to us. Now, when we make the margins clear, then we need to mark the tumor. That is macroscopic marking of the tumor 1 centimeter just beyond to the macroscopic margin of the tumor. That should be done in case of open as well as laparoscopic with a diathermy or many of the people use suture, right? In case of an upper polar or posterior locating tumor in laparoscopy, we sometimes do a flipping of the kidney. What is the flipping of kidney? We dissect the kidney as a whole and we flip the kidney in 180 degrees so that it is directly in front of us. The posterior part of the kidney is just front of us. in case of a posterior located tumor, and we do a flipping from superior to lower part in case if the tumor is lying in the posterior superior pole of the kidney. Next comes the hilar clamping. Now, hilar clamping can be done in many ways. Only artery clamping. In only artery clamping, the venous congestion is less, and so backbleeding during the surgery is less. En bloc dissection, en bloc clamping can be done, is done when we clamp both artery and the vein. Here the venous congestion is there. There will be venous congestion. Now there are many small tumors or peripherally located tumors where we can do the surgery without clamping in a very short period of time. For a very small tumor which is located peripherally, we can go for a zero ischemia one. Then there is a technique, I don't know, I have never used it, but it is in the books, that parenchymal clamping. With the parenchymal clamping, we can do a partial nephrectomy without clamping the hilum. That can be done either by hand-assisted one. We clamp where the tumor is located in the periphery, in the lower pole or upper pole, we can clamp the parenchyma with our one hand and we dissect the tumor. And another instrument is there that we can use is kidney parenchymal clamp, an instrument which I have never seen, but I have seen in the books, right? Now, there is a very new thing that has been, not new thing, it's a new procedure that has come, is selective and highly selective arterial clamping, where we dissect the arteries up to the level of segmental arteries and we clamp the selective artery which is supplying the tumor. So these are the various types of hilar clamping that can be applied both in open as well as laparoscopic partial nephrectomy. And these are the various instruments which we use for hilar clamping. The first two, the above one is the Satinsky clamp, which we use normally for an en bloc clamping, and another is the bulldog, both in open and laparoscopic one. The disadvantage of the laparoscopic Satinsky clamp is that, not a disadvantage, that we need an added 12 mm port for a Satinsky clamp, but for if we have a laparoscopic bulldog, we don't need another 12 mm port for the instrument. Then this is the technique of parenchymal clamping. This is the clamping. First one is the clamping where we have, I have shown you a clamping with the help of a vessel loop with an artery. And second is, this is how a kidney parenchymal clamp looks like, which we can use for during peripherally located kidney tumor. Now, then comes the resection of the tumor after marking. So we can resect the tumor. If the tumor is big, we can go for a happy nephrectomy where we remove 50% of the kidney. Then we can go for a wedge resection when the tumor is located in the peripheral lesion, or enucleation if we have a hilar tumor which is avoiding the hilar vessels, or there are multiple tumors. So this is the diagram. The first one is for hilar tumor. Then that is the diagram, schematic diagram for a wedge resection of the tumor. Next comes rhinorrhaphy. So we do rhinorrhaphy in two layers. In first, we repair the blood vessels in figure of 8 fashion, which whatever blood vessels are visible, mostly the segmental one, we do it with a proline, very small proline, 4050 proline in figure of 8 fashion. Then comes the first layer of rhinorrhaphy where we normally include the PCS if it is open, and then second layer where we do closure of the capsule. Now, how we close the capsule? The techniques can be either we go for an interrupted closure, we go for a continuous fashion where we use a sliding hemlock technique, or with or without bolster. Nowadays, we are not using bolster because it is not required, but later on it may cause it may show an artifact later on if we do a post-operative any imaging modality. Now, what are the sutures that we use for closure, rhinorrhaphy? Except the blood vessels, we can go for vicryl, we can go for monocryl, or nowadays we go for braided sutures. The advantage of braided sutures is that they maintain a tension. They maintain a tension in the kidney, so the chances, it is easier for the surgeon to do it. But the disadvantage being that it causes cut through. Cut through is very high with the braided sutures. The bar cut through, it comes out through the renal capsule. Now next is opening of the clamp. And opening of the clamp, ideally it should be, the warm ischemia time should be within 30 minutes, but it has been said that it can be extended up to say 50 minutes. Even I have seen many surgeons doing up to 50 minutes, and after that there is no problem later on. Then we close the zerota. We close the zerotas, and it has to be done because otherwise there will be adhesion in and around, and later on there may be problem. There may be problem if we have to go again later on. So in nutshell, these are the steps that we do for laparoscopic as well as open partial nephrectomy. Now coming to laparoscopic partial nephrectomy, the difference with the open partial nephrectomy is the position. Here the position is always lateral decubitus position with 45 degree up to 90 degree depending on the surgeon who is operating, what is his preferences. It has to be lateral decubitus into the edge of the table as already told by Dr. Samir. Now the port placements, for a port placement, the first port has to be always, it is always fixed, almost fixed for everyone. That is 2 centimeter above and lateral to the umbilicus, that will be the camera port. And after inserting the first port, second 2 ports has to be used. Right-sided port should be always 12 mm or 10 mm so that you can use energy source as well as the clip applicators can be inserted, because in 5 mm port, you cannot insert a clip applicator. And third port should be a 5 mm port, that is a retractor port or the left hand port. Fourth port on the right side is required to retract the liver. And fifth port in case of right side may be required in case of for an assistant, it may not be required. Okay, if we are using a Satinsky, another 12 mm port is required. So this is the port that has been, that we use. The first port is always the camera port, that is 2 centimeter above and superior to the umbilicus. Then the right hand ports, left hand port, and the 5 mm port. Now this is the first video that I am going to show you regarding lap partial nephrectomy. This will be on the right side. It's a very 3.5 centimeter hilar tumor on the right side in an 40 years old female. So these are the port side. These are the port. The first one is the camera port. Then the right port is the 12 mm port. Left is the 5 mm port, and the last port is here. I use the Satinsky, so it will be just below the umbilicus. So this is the first step, that is I am doing the mobilization of the colon. I think video is running, sir. Video is running, sir.
It is running. It is running.
So this is medialization of the colon. The adhesions has to be dissected down. Then we medialize the colon downwards and medially. This is the release of the adhesions with the anterior abdominal wall. We are releasing the colon. It has to be sufficiently done. This is the plane which we want to enter in the retroperitoneum. You can see the difference in the fat. So we can see the duodenum there. So we are doing duodenum and we are releasing the superior attachment with the liver. Superior attachment with the liver. This is the coccorization of the duodenum. We can see the tumor there. We can see the tumor there. This is coccorization of the duodenum is done. This is dissection of the superior pole of the kidney, removing the attachment with the, releasing the attachment with the kidney, with the liver, that is the peritoneal attachments we have removed. This is the first step, medialization of the colon with coccorization, complete coccorization. Then comes the hilar dissection. So I'm doing the hilar dissection. Here you can see the vein along with the artery. This is the hilum. We have to dissect the hilum. We have to skeletonize the kidney. I do the skeletonization of the artery as well as the vein completely, so that in case of any untoward event, I can do the radical nephrectomy as in there. So this is the complete dissection of the hilum. Then we are dissecting the tumor, mobilizing the kidney. Yes, we can. Here we have done the skeletization of the artery as well as the vein. Now the resection of the tumor, complete removal of the perinephric fat except that is in above the tumor. So 1 centimeter just lateral to the margin or macroscopic margin, we do a marking. Yes, this is the marking that we are doing. This is on the lateral side of the tumor. You can see the fat that I have kept there. This is medial margin of the tumor. Now clamping is done with a Satinsky. It's an en bloc clamping. I can see the both arms of the Satinsky. It is always required. Now the warm ischemia starts. Now the resection of the tumor resection should be in a conical way because the tumor extends down to the parenchyma. On the one hand, I have a suction, on the other, I have the scissor. So this is the PCS. Yes. Now this is the first step of the rhinorrhaphy. I am suturing the obvious vessels with 5-0-proline. Yes, this is a obvious vessel that can be seen. Now this is the first step where I am suturing the PCS, the first step of the rhinorrhaphy. The first layer of the rhinorrhaphy, I am doing it with a Vacryl 2-0. Here the PCS was open, so I took 2 sutures there. This finishes the first layer of rhinorrhaphy. That I put the final hemolog. This is the second layer of rhinorrhaphy. As it was a hilar tumor, so it has to be we have to be a little bit cautious. So this is the sliding hemolog technique that I have used for the rhinorrhaphy, the second layer. The traction is given by the hemolog that we apply through the capsule. So this is the second layer. Again, we are going. Yes. The final stitches, yes. That finishes the second layer of rhinorrhaphy. Now next is hemostasis. So for hemostasis, I don't use a bolster. I have used a Surgicel just over it, and I put a ferrocrylum over it always. I don't put any other hemostat. This is an Abzel as well and the Surgicel. This is the final after removing the clamp. This is ferrocrylum. This is the tumor, resected tumor with the paranephric fat. Next is a left-sided tumor. It's a big tumor on the 5 centimeter tumor, almost involving half of the kidney. I had to plan for a partial nephrectomy because patient is a diabetic, creatinine is of 1.6. So I planned for a partial nephrectomy. On the left side, the first thing that we do is mobilization of the colon, medialization of the colon, going up to the spleen, so that medialization of spleen is always done in the left side, as already told by Dr. Samir. Now, next is identification of the ureter and the gonadal vein is very important to identify the hilum, because gonadal vein directly takes you to the renal vein. So gonadal vein on left side first, then dissection up to going up to the hilum. So this is the dissection of the ureter hilum through the gonadal vein. Here gonadal vein I removed because she was an elderly patient. This is the dissection of the hilum. It was a little bit complex hilum because there were many segmental branches which were divided from the main renal artery. There was there was the early branching of the vessels. So here also I have used a Satinsky. So we are going to clamp it with hand block clamping is required. Yeah. So near the section of the tumor is done. As this is a very big tumor, so we cannot keep so much of fat here, perinephric fat. So this is the dissection. On one side I have a suction, on other I have the scissor. Here a big vessel. This is the segmental vessel that is going to the upper pole of the kidney has been cut. That I will repair later on. This is the PCS that has been cut. So it's the big tumor. It's a heminephrectomy. So the first step of rhinography, the resected upper polar vessel that I will repair with a 50 proline. Then the first step of the rhinography, I use the braided suture here. Here I'm doing a closure of the PCS. The first layer is I'm doing the closure of the first layer, the second layer. This is the first layer, second layer. This is the end result. So this finishes both the video. So thank you, sir.
Please unshare your screen, Devanga. Please unshare your screen.
Yes, sir. Yes, sir, done.
I know. Dr. Sarkar, please.
Yes. Thank you very much, Devango. I went offline for a moment because of some connectivity issues. So thank you very much, actually, Devango. That was a very detailed presentation, both with the steps of surgery and with the demonstrative videos. I think there'll be plenty of time tomorrow during the cases to discuss further about the surgeries and their complications and their indications. So, Anshuman, would you just quickly run through the very nice MCQs you've prepared?
It's 9 o'clock.
And so that we can conclude today's session.
Okay, sir. Should I start screen sharing?
Yes, please, please.
Tell you, 1 minute, sir.
लिफाफा ऊपर जाना पड़ेगा, ऊपर वो अलमारी के अंदर जो शीशा वाला नहीं है, उसमें देखो सामने में दिख जाएगा.
Can the organizers please share the slide? I am having some difficulties here, I think.
Okay, sir. So which one was self-assessment?
Self-assessment RCC, yes, self-assessment
Okay.
RCC.
Okay, okay.
So today's session was very nice with the 3 presentations the students have presented. I think the first 2 were very good, and the third one, slight caveat was there with, yes, this slide only, that as Ranjan correctly pointed out, we had to go with the current trends in the management of metastatic RCC. The things that have been going on in our textbook are now, with the daily new trends coming in, daily new drugs coming in, they are now things of the past mainly. So that should be discussed in just a way of a historical significance, something like that. and mostly we should know the current trends where we are going with the management of metastatic RCC now. So there are a few points that I'll be discussing in detail tomorrow also in our case discussion. But here is a set of 10 questions, 10 MCQ questions, mainly regarding only the metastatic RCC and its management. So I think I should start the presentation. Please get to the next slide, Uma. Okay, so the students, I think you all are ready. I should proceed, sir, with your permission. Hello, am I audible?
Yes, you are. You are.
Okay, sir. Okay, sir. Okay, sir. I'm going ahead with my presentation. So, with my set of questions. Now, the first question is: synchronous metastatic disease is present in what percentage of newly diagnosed RCC? Anybody, student? Anybody can answer?
D.
Yes, answer is D. It is 33%.
Okay, yes. The 1/3 cases of renal cell carcinoma they present with synchronous metastatic disease at the time of presentation. It's fine. Next slide, please. Okay. In the MSK prognostic for patients with metastatic RCC undergoing therapy with cytokine or chemotherapy, which of the following is not a predictor of poor outcome?
E.
First option is Karnofsky performance status greater than 80%.
It is A.
Lactate dehydrogenase.
E.
A. What should be the answer?
Karnofsky performance status will be less than 80%.
Lesser than 80%. Exactly. Yes, it is the right answer. One point that I would like to detail here that MSKCC, as you see the risk stratification tools, the two main, as already pointed out in the presentation, the two main risk prognostication tools used are MSKCC and the IMDC criteria. Both of these criteria have something that you should remember and you should notice that MSKCC is for patients who underwent therapy with cytokine or chemotherapy. In present day scenario, both these conditions, the cytokine therapy and chemotherapy, are outdated and are not routinely used. So MSKCC is not routinely used in present day scenario. The IMDC criteria is still used and it is for patients who underwent treatment with VEGF targeted therapy that at present is mostly the mainstay of treatment in combination with the immune checkpoint inhibitor. So you should notice this thing also while reading the book, that what is the caveat there, what all things are of importance. Anyway, coming to the next question, Ruma, please, next slide. Okay. Now, tumor attenuation measurement is used to assess the response to therapy by the following criteria of response evaluation to systemic therapy for metastatic RCC. Except anybody? I would like to go for this. Sorry?
SACT.
No, the answer is RACIST 1.1. So the point of giving this question is that you have to also once you are giving systemic therapy to the metastatic RCC patient, you have to follow up the patient and see whether they are responding to the therapy or not. And there are various criteria that have been put forward. The RACIST 1.0 was one of the most important and one of the first criteria that came in for all forms of solid tumors. It is also applicable for renal tumors, and in renal tumors, it has been now modified to RACIST 1.1. Various points are there, like change in the size of the tumor and other things. One important thing is RCC is tumor attenuation, that is the contrast enhancement. It is the mainstay of diagnosis on imaging features and also for response evaluation nowadays. That if in the presentation with focal therapy, one would remember that even the lack of enhancement after native therapies was treated as a good response. So if the tumor is less enhancing, after therapy, it is a good response to therapy. Now, these criteria, in the newer criteria, this has been included, but the RECIST criteria does not have this inclusion yet. So RECIST 1.1 should be the answer here. Okay. Coming to the next question, fourth question. Okay. The upfront cytoreductive nephrectomy is indicated in the management of metastatic RCC in all the following conditions, except A is surgically resectable primary with single peripheral lung metastasis, B, severe symptoms due to the mass of the primary, C, refractory hematuria, and D, resectable primary with single small hepatic metastasis. Anybody?
D.
The answer is D, resectable primary with single small hepatic metastasis. Fine. So the point here that I wanted to make is about the indications of cytoreductive nephrectomy. Is, as in the presentation also, there was a detailed description of cytoreductive nephrectomy, but in the current trends, it does not hold that very much important role as it used to hold in an era before the tyrosine kinase inhibitors came. So cytoreductive nephrectomy, after the TKIs have come in and immune checkpoint inhibitors have come in, cytoreductive nephrectomy is now not that important and is not used for similar indications as it was used earlier. So it is to be used in only those cases wherein we can get an R0 resection of the both primary and the metastatic tumor, or otherwise in those patients in whom the primary tumor is symptomatic due to hematuria, pain, or mass effect or paraneoplastic syndrome. So in such cases, it should be used. Now, one can say that in resectable primary with single small hepatic metastasis, one can go for hepatic metastasectomy, complete metastasectomy of the liver lesion, and also the primary cytoreductive nephrectomy. But in this case, one caveat is there that in liver metastasis, usually portends to a poor prognostic feature. So it is an intermediate or poor risk group of IMDC criteria, or further, when you prognostify with other criteria, it will come into poor groups wherein the chances of micrometastasis and other organ metastasis are very, very, very high. So in such cases, always systemic therapy is indicated. In any case where systemic therapy is indicated, systemic therapy is used first, then after response evaluation, cytoreductive nephrectomy one can go for, or given in the SIGN trial also. So that is one important thing. If systemic therapy is indicated, one should go ahead with systemic therapy before going for cytoreductive nephrectomy. That is the main point here. So the answer should be D. Here, upfront cytoreductive nephrectomy is not indicated. Next question, please. Okay. Which of the following molecules is not known to be upregulated as a consequence of VHL inactivation in clear cell RCC? A simple question. One has to just. Sorry?
GLUT1.
As far as I remember,
it is E, RAF1.
RAF1, exactly. It is E, RAF1. If you go with that flow chart of the VHL protein metabolics and everything, you will find that every other thing is present there, but RAF1 is not present. Anyway, next question, please. Okay. Factors associated with improved outcome after metastasectomy include all except
D. It is D.
Development of synchronous metastasis versus metachronous development. Yes. After a radical nephrectomy, if a patient presents with a metastasis, single pulmonary mets or liver mets, the prognosis is better if it would have presented synchronously with the primary tumor. So in metachronous presentations, the prognosis is better, always better. So it should be remembered. Next question. Okay. Which of the following agents has been shown to prolong progression-free survival in patients with metastatic clear cell renal cell carcinoma who have progressed on first-line therapy with VEGFR antagonists? Basically, what the question is that in clear cell RCC, we have already given the VEGFR antagonist and the patient has still progressed on response evaluation. Now what to do? What should be the second line therapy? It is A, axitinib. All other bevacizumab, interferon, alpha, high dose, IL-2, they will not be showing any progression-free survival, but axitinib is the second line choice. In the first line treatment, if we are giving a VEGFR antagonist, we have to use another TKI systemic therapy in the second line, or an immune checkpoint inhibitor if we have not used it before earlier. So that should be the answer. Axitinib is the answer. Next question. The overall response rate in metastatic clear cell RCC patients receiving frontline therapy nivolumab in combination with ipilimumab is. Kindly don't see this line. This is a copy paste error. Sorry. The overall response rate in metastatic clear cell RCC patients receiving frontline therapy nivolumab in combination with ipilimumab is. Say 15 to 20%. It is just a fact-based question. One has to remember such things. If you go through the data, it will be there. So anyway, next question. Okay, this is a trick question, I think, and even I am not sure of the answer here. I will ask teachers, senior teachers there to contribute. Anyway, a 58-year-old woman had a nephrectomy 6 years previously for a grade 2 clear cell carcinoma. She was incidentally found to have 3 left-sided pulmonary nodules. A physical examination is normal, as are all blood chemistries. CT of the brain, lungs, abdomen, and pelvis shows 3 pulmonary nodules with no associated hilar or mediastinal adenopathy, and a bone scan is normal. Which of the following is the most appropriate next step in her management? So a patient, 58-year-old female, underwent radical nephrectomy 6 years back. Now on follow-up has 3 pulmonary nodules on CT scan. Now what to do? The options are therapy with high dose IL-2, biopsy of a pulmonary nodule, mediastinoscopy followed by resection of the pulmonary nodules, and the observation, and E is IFN alpha therapy.
B. So for biopsy of the pulmonary nodules.
Biopsy. Okay. So here is some doubt. I think with the RCC metastasis, what the literature says that imaging features are many a time very much predictive of whether it is an RCC metastasis or some other primary. Rare things are rarely correct. So a second primary is always a rare thing. So it should be always thought of as a second option or third option wherever possible. So if a patient with a known malignancy presents with 3 nodules, now it is most likely a metastasis because there are 3 nodules. It was a primary pulmonary pulmonary tumor. It would have been a single nodule. First, this is the point. Then second is that imaging features, CT imaging features are many times very much predictive that they are with the enhancement features that it is RCC or not. So in this case, we may take it for granted that it is an RCC, and the answer, since it is a metachronous lesion, the good prognostic features are there. 58-year-old female is there, less than 60 years with a prolonged time after the primary treatment. Everything is going into good prognostic features. So I think directly we can go for metastasectomy in this tumor, in this case, without doing a biopsy. I would like to
one point actually. Can I?
Sir, exactly. I would like to know the opinion of the House on this question. I already said this is a controversial question.
Yeah, actually now it's a 6-year post-operative. Probably as per the sequence, everything is normal as per the standard protocol and follow-up schedule. But only a nodule and directly going for surgery, probably before that biopsy should be done to ensure whether it is secondary or maybe some other cause. Within 5 years probably, or within 1 to 2 years, then it is easy, because as per the standard principle and sequence of RCC,
yes, sir.
Metastasis
it is
more
very
than
rare.
5 years is quite rare.
More than, it is very rare.
So
Exactly.
better to have a biopsy, I feel.
Okay.
Yes, cystoscopy is not possible because there is nothing on the hilar or mediastinal adenopathy. So biopsy I think, is the first step. High dose IL-2 can given, it will go to ITU. Observation is not really necessary. So B is the answer. It has to be before you go ahead.
Okay, sir. Actually, I took this question from Campbell review only, and the answer there is C. So I tried to explain the answer with my points. Anyway, I was also in doubt. That's why I said that this is a controversial question, and I would like to know the opinion of the teachers here. Anyway, so B biopsy of a pulmonary nodule seems to be the rightful answer, the practical answer basically. So okay, no problem. Anyway, next question, Ruma. Randomized trials in patients with previously untreated metastatic clear cell RCC have demonstrated that the combination of pembrolizumab and axitinib is associated with better overall survival compared to sunitinib. The combination of avelumab in combination with axitinib is associated with better prognosis-free survival compared to sunitinib. Cabozantinib is associated with a better response rate and progression-free survival compared to sunitinib. All of the above or none of the above?
All of the above.
Exactly, all of the above. So the point here is that, as I was saying in the presentation, the current trends were to be given. The current trends. Is always a combination of immune oncology, immune oncotherapy, like immune checkpoint inhibitors with some of TKIs, this targeted therapy. This is the first line therapy in clear cell RCCs, as well as other forms also. Now it has come that this should be the first line therapy. And in all those where it cannot be used due to toxicity or patient not tolerating it, then only simple TKI, the targeted therapies or VEGFR are to be given. And in second line, after giving this immune combination therapy on the first line, the second line is again, if you have not used TKI, we can use TKI. If we have not used ICIs, immune checkpoint inhibitors, we can use the immune checkpoint inhibitors. And it all should be done under clinical trials so that further we have results to prove or disprove what we are doing. So anything, this was the point that I wanted to make. And I think with this, all the answers have already been discussed. So these were the 10 questions that I had prepared for metastatic RCC. Over to you, Sir Carter.
Well, thank you very much, Anshuman, for highlighting some brilliant points. And especially, I think your last quiz question was the message of the evening, at least regarding metastatic RCC, that in the 2 pandemic years, I think this has been the appearance of this, immunotherapy combinations are the biggest development in the management of, which is not there in the Campbell's edition. So all the students are exhorted to read these up because fantastic developments have taken. So essentially, the IO-TKI combinations are reserved for patients with very progressive, very aggressive disease. Cabozantinib and this lenvatinib with immuno-oncology treatments are good. But for most patients, I think this double immunotherapy. So I think that's a very good, very recent development, which is not in the textbook, which all the students should read up. So that's, I think we've had a very wonderful evening. I think there have been 3 extremely good presentations from the students. I must say, really, really good presentations from the students. And of course, we had 2 experts telling us how to do the various types of nephrectomy, radical and open, radical and partial, and open and laparoscopic. We've all learned a lot. And finally, Dr. Ashu has pointed out the salient developments in metastatic RCC that have come up in the last few years. And anyway, that sets the scene for tomorrow's meeting. We'll all meet at 10 o'clock tomorrow, and there will be 4 cases for discussion. So, are there any other comments from anyone? Shivajida?
No, that's fine. That's excellent evening, excellent academic evening. So we'll look forward tomorrow.
Yeah. Ranjan, would you please conclude the session? Are you there with us? Ranjan? Well, I think I thank all the participants in today's meeting, the faculty, Dr. Sameer, Dr. Sarma, Dr. Ashu, and the three extremely committed juniors who've done extremely well. I thank all the other senior participants for their comments, Harpreet and everyone. So let's meet again tomorrow morning. Okay?
Thank you, sir.
Good night, sir.
Thank you, sir. Good night.
Good night.